and welcome. This is Dr. DeMaio, and this is your OT 318, Week 10, Elbow Complex and the Forearm, Kinesiology. We're going to be talking about the elbow and the forearm, and here's a picture of the anatomy of the elbow. At the top, you see the humerus, and at the bottom on the left, we're looking at the humerus up top, and down at the bottom, you can see the radius is more lateral to the left. We're looking at an anterior view, and the ulnar is more medial to the right. You can see the bony articulations between the humerus and the radius. The capitulum receives the head of the radius, and the trochlea receives the trochlea notch of the ulna, and then the carotenoid fossa above receives the carotenoid process on the ulnar side, and on the radial side, looking at the lateral side of that image, at the very top above the capitulum, you see the radial fossa. We'll be talking about some of these ligaments here, and we'll discuss the movement of the elbow, and we'll look at also flexion, extension, pronation, and supination. And we'll be looking at the prime movers associated with it, the ligaments associated with it, and even some conditions associated with the elbow. So there is an animated tutorial that I downloaded, or didn't download. I gave you the link here. So if you'd like, at any given time, you may want to stop this right now and go through the tutorial and just kind of breeze through that. It's very well done. It's animated, so it keeps it simple. It gives a big overview. I kind of like to watch big overviews before I do anything, and I really suggest you do it. Okay, so when we're looking at the elbow joints, we have the humeral ulnar joint. That's between the humerus and the ulnar, and that's where the trochlea and the humerus meet, and they act like a hinge joint. So when you think about the elbow, most people think about that hinge joint, but then there's a humeral radial joint as well, and that involves the capitulum of the humerus and the head of the radius, and this permits a continuous contact between the radial head and the capitulum, and during pronation, supination, the head of the radius will actually spin in that capitulum. And there's a ligament that wraps around it called the annular ligament. So here are some of the ligaments, and you can see you have the radial collateral ligament, which is sometimes termed the lateral collateral ligament, it's kind of like in the knee, and the ulnar collateral ligament, which is sometimes termed the medial collateral ligament, and then you have the annular ligament of the radius. Now, these ligaments are very important. We're going to go through a little more detail on it. And so if you look in this, I gave you two links. This is PTs, young PTs, doing a VARUS stretch, or stress, excuse me, and a VALGUS stress on the elbow. It's a kind of an orthopedic test to see if there's any damage in the joint. If it's hypermobile, it could be some ligament damage. So what is VARUS and what is VALGUS kind of explains it pretty well in that video as you watch them. But here you'll see, I'm going to go forward one more slide. Where is that slide? A couple of slides. So you see, this is a valgus deformity, how the elbow kind of has this angle here. And if you were putting a valgus stress on it, you'd be pushing in this way and stretching this ligament here. What ligament do you think that is? Is that a medial side or a lateral side? That would be the medial collateral, the ulnar collateral ligament. If you push this way and put a stress on this ligament, you're putting a stress on the lateral collateral ligament or the radial collateral ligament. And so sometimes people have too much of an angle here. So the normal carrying angle for males, just like when you carry something like a bag, it actually is supposed to have this angle. And for males, it's 5 to 10 degrees. If females, slightly larger, 10 to 15 degrees. But if you have a 30-degree angle, this is called cubitus valgus. So it's like a knock-kneed of the elbow, you know. And then this is cubitus varus, it looks straight. Right? It's really not supposed to be straight. It's supposed to have a nice angle like this. So that's called a varus problem, or cubitus varus. And then this is gunstock deformity, where it's actually going even further medial here. So let's go back Oh, I can't go back, can I? Not good. Okay, so the annular ligament of the elbow is the third ligament of the elbow aside from the collateral ligaments we talked about. And its purpose is to hold the head of the radius close to the ulna. And this is allowing the spinning of the radius so it can pronate and supinate without any interruption. But a torn annular ligament can occur, and it could actually cause an elbow dislocation or subluxation, or sometimes they call it NURSEMAIDS deformity in a baby. So look, this person grabbed it. Ever see somebody do this? Grab their kids by the arm and drag them across the street and they're hanging by one arm? Not a good practice, especially what we learned about the clavicle being connected to the sternum. The only really nice connection of the entire whole upper extremity to the body wall is at the sternoclavicular joint. So here's a baby being pulled, and it caused a partial dislocation. And what happens, the ligament's very elastic like in a baby, and sometimes it literally pulls and slips out of place and gets stuck in between there. Has many different presentations. But you can get an elbow dislocation by tearing the annular ligament too. And here's a falling on an outstretched hand. We talked about that a little bit last semester, and we'll talk about it more when we talk about the wrist, the Fuchs injuries. And it's very common in gymnastics with a bad landing or something like that, and it tears this annular ligament. You notice how the annular ligament goes around a circle right around the head of the humerus radius to hold it in place. And this would actually dislocate or subluxate and then dislocate. A subluxation is less than a dislocation. Sometimes people use it interchangeably. Now, the textbook, and I actually found the same image from our textbook on the computer. I don't know how I did it, but I did, thank God. So it says that the radius has a curved shape. You see how it curves like this? And it's thicker at the end here. Up here, it's like a normal angle. And if it stayed like that, and you tried to pivot your arm and your wrist, it would dislocate the wrist. The distal aspect of the radius would dislocate from the carpal bones. So because we have this angle, it allows the radius to pivot around the ulna. So the radius is the one that's moving. The ulna are staying stationary, and the radius pivots around. Now, distally at the forearm, we have this thing called the articular disc. You can write it with a C or a K. This disc has ligaments around it too. We'll talk about those ligaments more when we talk about the wrist, but there's a disc between the radius and the ulnar, and so it holds the radius in place so that it can spin around at the ulnar down there. So the radial head spinning at the top within the capitulum, held by the annulus. And down at the bottom, the articular disc allows for the radius to spin over the ulna and stay in its place because there's ligaments there. So here it is. This is the articular disc, which really is made up of several ligaments as well, and cartilage in there. So we have another thing called the interosseous membrane, and the interosseous membrane is connected between the radius and the ulna all the way down, and it does prevent abduction or adduction of the radius, so it can't separate from the ulna or get pulled away or pulled too close to it. So it maintains that, but also it allows for flexion, extension, and rotation of the radius. So you can still flex and extend the radius because you have this holding it in place. It's not flopping in and out between each other. But it also serves as a site for muscle attachment and acts as a mechanism to transmit forces proximally through the arm. So it helps to transmit forces through the arm so that when you land on your outstretched arm, it gives you some support between these two, like a shock absorber. And then the distal radial ulnar capsule provides stability at the distal radial ulnar joint. So there is a capsule around this as well that provides stability distally. So it's important to note that proximally, the medial and the lateral collateral ligaments give most of the stability to the elbow joint. The annulus of the radius prevents the radius from popping out of the joint. So remember, we have a hinge joint between the humerus and the ulnar up top at proximal part of the elbow, and the medial or ulnar collateral ligament and laterally the radiocollateral ligament play the role of really stabilizing the elbow. The annular ligament stabilizes the radius within its space so that it can spin without popping in and out. If that was torn, you'd get a dislocation of the radius, the radial head. So the radius rotates around the ulna. The distal radius is larger. If you looked at the shape of that radius, it had that angle, but it also broadens, becomes very broad at the distal portion of the radius. And the shoulder rotation can sometimes substitute each motion of pronation and supination. So when you're testing somebody for pronation and supination of the forearm, sometimes people can use their shoulder and do it. The way to overcome that or prevent that from occurring is to hold the humerus tight against the thorax with the elbow bent at 90 degrees, then test pronation and supination so that the shoulder doesn't get involved. Now, when we're looking at the myology of the muscles of the forearm, elbow and forearm, some books look at it different ways. Here's a different way of looking at it first, and we're going to go back to the other way, is that if you wanted to palpate the bellies of the muscles, there are muscles that are proximal, bellies of the muscle that are proximal to the elbow, and there are bellies of the muscle that are more distal. And the bellies of the muscle that are more proximal are the biceps brachii, the brachioradialis, the brachialis, and the triceps brachii. Now, it's not talking about actions, it's talking about location of the muscle bellies. And now, distal to the elbow joint is the brachioradialis belly, the pronator teres, and the pronator quadratus, and the supinator, which are very hard to palpate. Those two are very deep. So when you look at the deep elbow muscles, you can see here we have the brachialis up top, and that would be below. So if you look at the right side of the screen, you're seeing the deeper view. You look at the left side of the screen, it's more superficial. So let's look at the right side of the screen for a moment, and deep to the biceps brachii is the brachialis. And you can see the biceps tendon cut there, which helps to give some support to the elbow. And then you see on the lateral view, to the left of your image, the left image shows you the brachioradialis very clearly. And you can see the pronator teres. And then deep to that area, by the cubital area, antecubital area, you see the supinator, and then deep distally, you could see the pronator quadratus. Now, when we flex our arm at the elbow, the muscles with the greatest mass that pass over the anterior elbow joint and perform elbow flexion are several. One is the biceps brachii. You can see how it has the two heads there. One coming from the coracoid process, one coming from the supraglenoid tubercle, all coming into the common insertion at the radial tuberosity. And then the next large muscle that has a large mass passing over is the brachioradialis. Now, most of the belly is distal to the elbow joint, whereas if you looked at the biceps and the brachialis, they're more proximal. So here you see the brachioradialis coming from the lateral supracondylar ridge of the humerus and inserting into the styloid process of the radius. And so the brachioradialis can enable flexion of the elbow joint, but it also assists with pronation and supination of the forearm. And these two movements allow the forearm and the hand to turn so that the palm faces up or down. The arms are the only part of the body that can do this. Now this muscle, the brachioradialis, if you list it like linear and trying to understand the actions of this muscle, and it says it flexes the elbow, and it pronates the forearm, and supinates. Well, you have to ask yourself a question as soon as you read that. How can one muscle both pronate and supinate? Because they're opposite actions, and it's all about your starting position. When you start in a neutral position, kind of like you're going to do a choo-choo train with your thumbs up and your fingers straight out, and you bring it, choo, 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 you know what I'm talking about. You see the elbows are in flex position, and the hands are like you're going to clap your hands. That position, fingers straight out in front of you, that's a neutral flexion, right? There's no need to pronate or supinate. But if you started out in the pronated position and then you started to flex the elbow, it actually pulls from the radial styloid up, and so it's supinating from the pronated position. Now, if you started from the serving the soup position and then you flexed your elbow, it would actually pull that start of the process from the lateral side towards the midline, and that means it's going to pronate as it flexes. So brachioradialis is a unique muscle, kind of like the pec major. Now, also a third muscle that has the greatest mass that passes over the elbow joint in the anterior side is the brachialis. The brachialis performs pure flexion in a neutral position. It does not perform any kind of supination of the elbow or pronation, whereas you'll see that the biceps brachii can also supinate. Well, the brachialis can't. Why? Because it's the way its origin is, plus the brachialis can have no effect on the shoulder joint, whereas the biceps brachii can help flex the shoulder because they start above the humerus. So other muscles that assist in elbow flexion that pass over the anterior joint, believe it or not, the extensor carpi radialis longus. And what's the deal with that? How does that flex the elbow? Well, it starts slightly above at the humerus and the medial, at the lateral epicondyle of the humerus, and it's on the other side. You can't see it here. It actually can flex the elbow when pronated. So the pronated teres is involved in this thing, when the pronated teres pronates the forearm, and then you try to bring your elbow into flexion, the extensor carpi radialis longus gets engaged and flexes it. It's kind of like people call them reverse curls, you know. Yeah, I don't know if you've ever seen that. So elbow flexion, you have biceps elbow flexion and forearm supination by the biceps brachii. The brachialis can do elbow flexion, and as we said, it's just pure elbow flexion. The brachioradialis can do flexion of the elbow with the forearm in neutral position, and it can also do pronation or supination depending on the starting position. And the pronated teres assists in elbow flexion and pronates the forearm. So when we talk about extension of the elbow, that's when you straighten your elbow out. The triceps and the anconeus are posterior. Here's the triceps, 3 heads of the triceps. You have a long head, a lateral head, and a medial head. This is the medial head here. And then distal over here, this green guy, is the anconeus, a very tiny muscle that helps to lock that elbow out. Inhibition of the biceps. Now, if you do flexion of the elbow with the forearm, supination involves activation of the biceps. But the biceps both supinates the forearm and flexes the elbow. So you can actually inhibit the biceps. If the task requires the elbow flexion with the forearm in pronation, the brachialis and the pronated teres will be used. If the task requires a more powerful elbow flexion, the biceps get recruited and the pronated teres will neutralize the tendency of the biceps to supinate. Now we have 2 different nerve supplies that help that. So when the forearm is in a neutral position, the muscles that flex the elbow are the brachioradialis and the brachialis. In forceful flexion, the biceps will be called upon and the pronated teres. Pronation and supination arise from forces that pull the radius across the forearm toward the ulna. In supination, muscles that supinate the forearm are the supinator and the biceps. The contraction of the biceps spins the top of the radius, producing supination because of its insertion. In pronation, muscles that pronate the forearm are the pronated teres and distally the pronated quadratus. So pronation, supination. I said this already, that the brachioradialis can function as both a pronator and a supinator. And we talked about how, as the forearm is pronated, the brachioradialis force is dorsal to the axis of the supination, and pronation and supinates the forearm. When the forearm is fully supinated, serving the supposition, the brachioradialis directs a force on the volar side of the axis and causes pronation to the mid position. Isolation of the supinator. The biceps is innervated by the musculocutaneous nerve. It's larger and stronger than the supinator. The supinator is radial nerve innervated, but it's not always active. So quieting the biceps and performing supination with only the supinator helps to determine the function in the radial nerve. And you do that by stabilizing the arm in a flexed position. Extending the elbow without the extensors. Well, you can link the elbow extension and shoulder flexion. So by linking elbow extension and shoulder flexion, it can happen. If the chain is stabilized at its distal end, shoulder flexion will extend the elbow. So this is, in your book, it talks about a woman with, I think, a C5 paraplegia and didn't have control over that. So you can actually link extension of the elbow because it's at a different nerve level, and then shoulder flexion. By linking elbow extension and shoulder flexion, you can actually extend the elbow without the elbow extenders. So in review, the prime movers of flexion of the elbow are the biceps brachii, the brachialis, and the brachioradialis. And the prime movers of elbow extension are the triceps brachii and the anconeus. The prime movers of forearm pronation are the pronator teres and the pronator quadratus. And the prime movers of supination of the forearm are the biceps brachii and the supinator.